Hello, I'm Dr. Anthony Wheeler, and I'm telling you everything that you need to know about pathology. You're probably wondering, what's going on with this person's hands? Well, that's digital clubbing, right? You remember that? Digital clubbing, classically seen in Tetralogy of Fallot, right? Speaking of which, what are the four cardiovascular features, I should be specific in my language, of Tetralogy of Fallot? Overriding aorta, pulmonic stenosis, ventricular septal defect, and right ventricular hypertrophy, right? You remember that. I know you know that. We're going to be talking about congenital heart defects pathology and much more in this presentation. All this material is in your book, Medical School Pathology and Step 1 Review. You can scan this QR code and find updated material, lectures, handouts, etc. to make sure you succeed, do the best that you can on Step 1 and in med school for pathology specifically. This is important for being on the boards and wards as well because a lot of information comes up again and again and again, and it all ties back to pathology. So congenital heart defects. Congenital heart defects are congenital, hence they occur early on. How early? Well, in embryogenesis. Congenital heart defects specifically between weeks 3 and 8. Congenital heart defects are observed in 1% of live births. And most congenital heart defects are incidental, not important, no big bad signs, right? Not clinically significant. Congenital heart defects frequently cause shunting between the right and left circulations, the right being the pulmonary circulation and the left being systemic circulations. The shunt can gradually reverse, even though defects with left to right shunting may be largely asymptomatic at birth. Pulmonary hypertension and pulmonary hypertrophy are caused by increased flow via the pulmonary circulation. The shunt gradually reverses due to increased pulmonary resistance, causing late cyanosis, which is known as what? Eisenmenger syndrome. And this is along with right ventricular hypertrophy, polycythemia, and clubbing. Now, my savvy pathologists out there and internal medicine people, they know what polycythemia means. If you know, let me know, right in the comment or wherever. You're smart, you can figure out how to let me know. And if you're not subscribed, make sure you're subscribed if it's available. Now, congenital heart defects. Well, cyanosis is typically the first sign of right to left shunting defects soon after birth. Here we have an image of what? Digital clubbing associated with what? Tetralogy of Fallot. And what are those four cardiovascular classic findings that define Tetralogy of Fallot? Let me know somewhere. I already told you, and I'm sure you already know. But just in case, I'll tell you right now because I like you. Overriding aorta, pulmonic stenosis, VSD, and right ventricular hypertrophy. And here we have an image of a vascular surgery taking place due to a congenital heart defect. All my radiologists out there and future radiologists can recognize the transposition of the great vessels on this X-ray. And here's a cartoon showing a classic congenital heart defect, a patent Ductus arteriosus. And here we have an X-ray of a patient with Tetralogy of Fallot. And a particular congenital heart defect to be aware of is a ventricular septal defect. A ventricular septal defect is a flaw in the wall that separates the right and left ventricles, or septum. Ventricular septal defects are the most common congenital cardiac condition. Ventricular septal defects are inextricably linked to fetal alcohol syndrome. Mama shouldn't be taking shots, throwing shots back if there is a developing birth, let's say, right? Wouldn't recommend it. Ventricular septal defect results in a shunt from left to right, as you can see here, indicated by this cartoon, as well as other features of Tetralogy of Fallot. Age at presentation and defect size both depend on the ventricular septal defect size. Here we have an echocardiogram of an image of a moderate VSD. Large ventricular septal defects can cause Eisenmenger syndrome. And the treatment of a large ventricular septal defect involves cardiac surgery. Small ventricular septal defects are actually frequently asymptomatic. Small flaws actually might naturally close. Now here we have a cartoon of a ventricular septal defect. Can you see what's happening here? And note that in this cartoon, we have a representation of another congenital heart defect. You can see in the various figures that figure A shows the structure of blood flow in the interior of a normal heart, whereas B shows two common locations of a VSD. And here we have imaging from a 12-year-old male that had a small, muscular, apical ventricular septal defect. Now, keep in mind that there are other regions in the heart that can have defects, such as an atrial septal defect. Now, an atrial septal defect is a hole in the wall that separates the right and left atria. Regarding atrial septal defects, the ostium secundum, right? The ostium secundum is the most prevalent cause of atrial septal defects, right? Like 90% of cases. And what condition is linked with an ASD? Down syndrome. Yes, Down syndrome is linked to the osteoid primum type of atrial septal defect. An atrial septal defect results in a divided S2 and a left to right shunt on auscultation because there's an increased blood flow in the right heart that delays closure of the pulmonary valve. Paradoxical emboli are potential complications of an ASD. And here we have a cartoon of an atrial septal defect. And here we have imaging, specifically an abnormal chest X-ray, as seen in a patient that has atrial septal defect. And this image is showing an ultrasound picture of a heart that only an advanced radiologist would be able to decipher, showing an ASD. And here we have a transesophageal echocardiography showing a particular heart defect, right? As well as a CT scan on the right. Now let's talk about a patent ductus arteriosus. What is that? Well, a patent ductus arteriosus results from failure of the ductus arteriosus to close. A patent ductus arteriosus is linked to congenital rubella. A patent ductus arteriosus results in a left to right shunt between the pulmonary artery and the aorta. The ductus arteriosus generally diverts blood away from the lungs and toward the aorta during development. The patent ductus arteriosus is typically asymptomatic at birth with a holosystolic, machine-like murmur. A patent ductus arteriosus may result in lower extremity cyanosis and Eisenmenger syndrome. Treatment of a PDA involves indomethacin, which decreases prostaglandin E1, resulting in the PDA closure. Note that PGE1 maintains patency of the ductus arteriosus. With regards to other issues, let's talk about Tetralogy of Fallot, which is a congenital cardiovascular anomaly that results in right ventricular outflow tract stenosis, right ventricular hypertrophy, a ventricular septal defect, and an overriding aorta, as indicated on this cartoon here. Early cyanosis is caused by right to left shunting, and the degree of stenosis dictates how much shunting and cyanosis is present. In response to a cyanotic spell, patients with Tetralogy of Fallot are taught to squat because the artery resistance is increased, and this reduces shunting and increases the blood flow to the lungs. On radiology, the heart in a patient of Tetralogy of Fallot looks like a boot, called a boot-shaped heart. And here, again, we see digital clubbing associated with Tetralogy of Fallot. You will be asked about this. Can you recognize this heart? Would you say it has a boot shape? Here we have an image from an autopsied specimen that has been opened through the anterior wall of the right ventricle to show the cardinal features of Tetralogy of Fallot. Do you see that? And here we have transposition of the great vessels, right? So let's talk about that. Transposition of the great vessels is characterized by the aorta and pulmonary artery emerging from the right and left ventricles, respectively. Gestational diabetes is actually a risk factor for the transposition of the great vessels. Transposition of the great vessels has an early cyanotic presentation. And note, systemic and pulmonary circuits do not interact in patients with transposition of the great vessels. After birth, shunt formation is necessary for survival. This enables the blood to mix. Prostaglandin E1 can be given to keep a patent ductus arteriosus open until a permanent surgical repair is made. Transposition of the great vessels results in left ventricular atrophy and right ventricle enlargement. And that makes sense, right? Because the right ventricle with transposition of the great vessels is actually pumping out to the systemic circulation, which requires it to have the strength to act against that peripheral resistance, hence the enlargement, and vice versa for the left ventricle, which is why it becomes atrophied. Now let's talk about Truncus Arteriosus. Truncus Arteriosus is characterized by the emergence of a single sizable vessel from both ventricles. And this is because Truncus Arteriosus is due to a failure of division. Truncus Arteriosus has an early cyanotic presentation. Before the pulmonary and aortic circulation separate, deoxygenated blood from the right ventricle and oxygenated blood from the left ventricle combine. Now let's talk about tricuspid atresia. Tricuspid atresia is due to failure of the orifice of the tricuspid valve to form. In tricuspid atresia, a hypoplastic right ventricle is present. Tricuspid atresia frequently results in a right to left shunt and is linked to atrial septal defect. Tricuspid atresia has an early cyanotic presentation. Now this is an important pathology that you will definitely see. Coarctation of the aorta. Coarctation of the aorta results in an abnormal narrowed portion of the aorta. Coarctation of the aorta is separated into juvenile and adult versions. Juvenile version of coarctation of the aorta has a patent ductus arteriosus, and in the infantile form is connected. Coarctation is located distally after the aortic arch and proximal before the patent ductus arteriosus. Coarctation of the aorta presents in babies as lower extremity cyanosis, mostly after birth. And coarctation of the aorta is linked to Turner syndrome. In the adult version of coarctation of the aorta, a patent ductus arteriosus is not connected regarding the adult form of coarctation of the aorta. After or distal to the aortic arch is where the coarctation is typically located in adults. Coarctation of the aorta in adults typically presents with hypertension in the upper extremities and hypotension with weak pulses in the lower limbs. Radiology of coarctation of the aorta classically shows notched ribs on chest x-ray due to collateral vessels. Coarctation of the aorta is linked with bicuspid aortic valve. And with that, we've completed a lecture that has a lot of material that shows up and that's testable, because some of these features are so classic, so you must know them. I guarantee you these will show up. Make sure you're reviewing your book. Make sure you subscribe so you don't miss out on what's posted. Make sure you have access to the website so you have all of the materials to succeed, because I want you to win. I'm rooting for you. Your friends are rooting for you. Everyone's rooting for you. Your family's very proud of what you're doing. Let's keep up the good work. Keep studying. And I'll see you next time.